on behalf of Dr. Abdul Ghafoor, Senior Consultant in Infectious Diseases and Managing Trustee of AMR Declaration Trust. This webinar session will be featuring a presentation on antimicrobial resistance in respiratory infection, which will be presented by Dr. Anup, our warrior, a lead consultant in infectious diseases at Aster Medicity, Kochi. Dr. Warrior is also the Group Chief of Medical Affairs and Quality for Aster. He brings with him 18 years of experience in clinical infectious diseases, hospital infection control, and antimicrobial stewardship program, along with 11 years of experience in healthcare quality and medical administration. And the session will be moderated by Dr. Dona Mathew, consultant microbiologist and infection control head at Smita Memorial Hospital and Research Center, Thodupuzha, Kerala. This institution has received the Best Performance Center Award for Private Firm Integrated Counseling and Testing Center for 2024, and has also been recognized as a Center of Excellence in Infection Prevention and Control and Antimicrobial Stewardship by CAHO 2025. The AMR Declaration Trust is a public charitable trust founded on the principles of the Chennai Declaration document and initiative. Our primary mission is to stimulate discussion, inspire action, and explore innovative solutions to address the global challenges of antimicrobial resistance. We sincerely acknowledge the unrestricted educational grants from pharmaceutical companies such as FIDSA and FIDSA, which have enabled us to organize this webinar series. Without further ado, I invite Dr. Dona Mathew to take over and moderate today's session. Dr. Dona? The mic is off.
Hi everyone, I'm Dr. Dona Mathew. I am moderating this topic of multi-drug resistant organisms of respiratory infections by Dr. Anup. So I invite sir to have the session on the topic.
Can I go ahead and share my screen? Yeah.
I am too.
Afrin, can I start?
Yes, sir. Yes, sir. You can start, sir.
Thank you all and good evening. So this evening, we will be looking at the antimicrobial resistance and respiratory infections with a specific focus on how we would impact our treatment and outcomes. So to start with, this is the WHO's global cause-specific mortality. And you see that the respiratory infections figure among the top 4. Right? It is the 4th most common cause of death around the world. So that is one of the reasons why we are focusing on this. In terms of its incidence or prevalence also, it is one of the commonest infectious diseases around. And this data from WHO shows that the community acquired pneumonia and hospital acquired pneumonia, etc., they have a significant outcome impact in terms of being the 4th commonest cause of death worldwide. If you look at the incidence of lower respiratory tract infections, which contribute to this mortality, this is again a snapshot from the same data, and you see that India has one of the highest age standardized incident rate of LRTIs. This graph is from 2019. So while respiratory tract infection remain one of the biggest causes of mortality, our country or India, we have one of the highest incident rates of this too. When we look at the causes of lower respiratory tract infections, and I am focusing on 2 groups here. We are focusing on community acquired pneumonia and hospital acquired pneumonia. This being the major severe kinds of respiratory tract infection, and also those which are or which contribute to the data on mortality that we saw. So 1/3 of these community-acquired pneumonia. So the first section, we would be briefly looking at community-acquired pneumonia, and we see that 1/3 of community-acquired pneumonia is caused by Streptococcus pneumoniae. And as in other parts of Southeast Asia, in India, we have about 20% or more of CAP being caused by Klebsiella pneumoniae. This has been true, as I mentioned, for other parts of Southeast Asia also. Mycoplasma and Legionella are the atypical pathogens that we focus in terms of when we plan our empiric cover. These constitute about 7 to 10% in our subcontinent. Now, the AMR in pneumococcus is predominantly focused on 3 groups of antibiotics. So these are the 3 groups of antibiotics which we use empirically to treat lower respiratory tract infections: the beta-lactams, macrolides, and fluoroquinolones. Pneumococcus has evolved resistance mechanism for all these 3 commonly used drugs against pneumococcus. The prevalence of this varies. The penicillin resistance varying from anywhere between 10 to 40%. Cephalosporins resistance being highest for cefuroxime, nearly 30% for cefuroxime, a bit lesser for ceftriaxone, and quite rare for ceftaroline. The resistance to macrolides is quite significant, 20 to 40%. Hence, again, when I come to the empiric therapy, we'll be speaking more on the importance or what does it imply. Fluoroquinolone resistance is still quite low, less than 1 to 2% as per the data. We have more and more serotypes being covered in the major pneumococcal vaccines. We had the polysaccharide 23 valent for a very long time. Then we had PCV7, PCV13, and now we are going with pneumococcal conjugate vaccine 20. So just an interesting comparison between what vaccine does and how the serotypes change and how it affects the antibiotics. So what this graph tries to show is that with the introduction of a effective vaccine, the initial serotypes, which are in red of the pneumococcus, it plummets down, and the non-vaccine covered serotypes, which is the green, sort of goes up. So as this grows up, these are also resistant to the primary antibiotics which we used to treat the earlier serotypes. So the primary antibiotics in this graph is shown as that yellow pill box. So as the green rises, the non-vaccine serotype rises, they are also resistant to the primary antibiotics, and hence we hit them with a new class of antibiotics, which is shown in the blue pill box. Now, as the vaccine evolves, we add more serotypes. So these green serotypes are also now covered, as you see with the green syringe there, and they also plummet down. And then you have the rest of the serotypes, which is still uncovered by the vaccine, going up and then developing resistance to the secondary antibiotic which we use. So which means that now we are going to use a third line antibiotic for those. So this is an interesting mix and match between how vaccines and AMR act for this particular bug. So this was also sort of looked at and understood in this systematic review and meta-analysis, which was published about 2 years ago in Clinical Infectious Diseases, that with the vaccine escape serotypes, you could find more resistance to the commonly used antibiotics earlier. In terms of our empiric therapy to community-acquired pneumonia, ceftriaxone has been the backbone for most of us. Of the cephalosporins which we use for CAP or community-acquired pneumonia, this has been the first line, ceftriaxone. So if you look at this data, this was published in 2024, February last year, looking at about 15,000 plus isolates from the Atlas program over about 8 years. So in India, if you look at it, the map, it had about 15% of ceftriaxone resistance. And this resistance is increasing. So the susceptibility in Asia was 83, it dropped to 75. That means overall in Asia, about 25% of them now are ceftriaxone resistant. So this is the second important resistance mechanism which impacts our empiric therapy, or which could impact our empiric therapy. So we looked at the penicillin resistance and general cephalosporin resistance, and here we are looking at very specifically ceftriaxone susceptibility, because that's one of our backbone antibiotics for CAP. But when you try to dwell into the literature on how these resistance rates are impact the outcomes for treating community-acquired pneumonia from pneumococcus, the data is a bit wishy-washy. We are unable to find very high quality, strong data saying that this AMR spectrum, which we discussed, penicillin resistance and cephalosporin resistance and ceftriaxone resistance, etc., whether that has a profound clinical outcome in terms of either mortality, length of stay, ventilation, ICU stay, all these were looked into and a clear information or clear data could not be identified. So this publication is on pediatrics, though we don't have much of, or different data we do not have in adults too. Now, following pneumococcus in CAP in Southeast Asia and in our part of the country, as we saw in the systematic review, Klebsiella was the next common. Now, why is Klebsiella common in community-acquired pneumonia? Two of its biggest risk factors mentioned, diabetes and alcohol use, are quite common in part of the country. We are one of the diabetic capital of the world, in fact. And this is being one of the highest risk factors for Klebsiella causing community-acquired pneumonia, alcoholism and malignancy, and liver disease, transplant, etc., more of healthcare associated pneumonias. So even in this, from the community-acquired pneumonia perspective, especially severe pneumonia, which lands up in the ICU, etc., what we see is that about a third of them are with a strain which is called as hypervirulent Klebsiella pneumonia. And this prevalence of this hypervirulent Klebsiella pneumonia among the pneumonia that causes pneumonia, the CAP, etc., or other Klebsiella infections have been going up from about 27 to 38 over the years. And also, serious aspect of it, is in the hospital environment or a hospital acquired sort of infection, the carbapenem resistance among this highly virulent species is also going up from around 10 to 16%. So on one side, we have about a third or more of a strain of Klebsiella called hypervirulent Klebsiella, which has significant virulence aspects, high virulence aspect. And on top of this virulence, now this is also developing carbapenem resistance. So this is a snapshot of the distribution of this hypervirulent Klebsiella pneumonia globally. And as you see, Asia is second in the line. On the right, what you see is the impact of this. So compared to a usual Klebsiella pneumonia infection, the chances of developing meningitis is very high for this. And other disseminations like liver abscess, renal abscess, and even endophthalmitis can be expected with this hypervirulent Klebsiella. So very highly prone for dissemination, including into the central nervous system. When you look at the carbapenem resistance in this group, again, China had one of the highest rates, closely followed by India and the Middle East. So India, the carbapenem resistance among these strains were about 56%. If you look at the breakup in terms of mechanism of resistance, you see that 27% being NDMs, metallo-beta-lactam NDM, and about 67% being OXA48. So what is the implication or the practical application of knowing this? The practical application of knowing this background that in the community, Klebsiella pneumonia can cause community-acquired pneumonia, and that a third of this could be hypervirulent strain, etc. The risk factors of diabetes has got a significant odds ratio or a higher risk of developing this, similar to alcoholism. And acquiring Klebsiella from the community is again more likely due to the hypervirulent. So somebody comes with a community-acquired Klebsiella infection, we are more likely to suspect this, especially if they show signs of dissemination, like liver abscess or meningitis or that sort of dissemination, endophthalmitis, etc. Among the community-acquired strains of hypervirulent Klebsiella, these tend to be younger, and those with documented dissemination, especially liver abscess, were found to have higher chances or higher or difficult outcomes compared to the usuals. Now, the third bug, which is in our spectrum for community-acquired pneumonia, is Mycoplasma. And macrolide resistance among this Mycoplasma is becoming a major threat for us in terms of managing CAP. The macular resistance ranges in our area, Asia Pacific region, from about 26-27% to nearly 100% in some parts of the world. So this is a snapshot of the global macular resistance in Mycoplasma, and you see that China tops this, and India, Africa, some parts of Northern Europe, South America, etc., are on the same boat in terms of having between 11 to 20% or so of macular resistance. Now, this macular resistance in Mycoplasma has a certain clinical impact too. It has been shown that these people tend to have longer duration of cough and longer duration of febrile days, or they tend to remain febrile longer than macular susceptible infections or pneumonias, and they have increased length of hospital stay. So even though there is no significant mortality impact, it could have morbidity impact in terms of longer fever, longer cough, and increased length of stay. Sometimes this may produce a significant exotoxin called as the community-acquired respiratory distress syndrome toxin, which can cause severe Mycoplasma infections with a lot of extrapulmonary manifestations, and this is associated with significant mortality too. Since tuberculosis remains a differential diagnosis for almost any sort of lung infection or lung infiltrates in our country, an interesting part of the Mycoplasma pneumonia is that the pleural effusion that is associated with Mycoplasma, and we should remember that this pleural effusion can happen in 20 to 25% of people with Mycoplasma. It mimics TB in terms of its exudative nature and being predominantly lymphocytic, so with a higher ADA. So Mycoplasma pleural effusion is typically lymphocytic with exudative nature and with high ADA. So what this algorithm on the right shows is that usually the ADA tends to be under 40, but between 40 to 70, Klebsiella pneumonia or TB both are possible. And here the differentiation is mostly with CRP. In tuberculosis pleural effusion, CRP would probably be on the lesser side. In this study, it was quoted at less than 10. If it is more than 70, that is the ADA, it's most likely due to tuberculosis itself. So just a sort of caveat that because in community-acquired pneumonia in part of our country, we definitely consider tuberculosis as one of the differentials, that Mycoplasma also can result in a lymphocytic exudative pleural effusion with high ADA, which should not be confused with TB. In terms of the treatment potential for this macrolide resistance, this is again a systematic review and meta-analysis done last year, published last year. So in adults and children above the age of 8 years, of the many tetracyclines group, tetracycline, plain, doxycycline, minocycline, etc., minocycline showed the best results, followed by levofloxacin. So in children above 8 and in adults, either minocycline or levofloxacin had the best outcome impacts or outcome efficacies for treating macrolide resistant Mycoplasma. In the younger age group, levofloxacin was associated with more adverse events, specifically CNS and musculoskeletal, and therefore moxifloxacin, which was a safer option in children and almost as good as effective in less than 8 years of old. Now, trying to summarize all this, what could be the impact on this empiric, or since we are using a lot of rapid point of care molecular diagnostics for our severe pneumonias, what could be the impact on this empiric or PCR targeted therapy, which we start basically in an hour or two after we are able to get a respiratory sample? We know that beta-lactam and macrolide are still the standard of care. So this is a publication about 2 years ago. And in terms of the overall outcomes with various groups of antibiotics, it concluded that treating community-acquired pneumonia with a beta-lactam and a macrolide remains the standard of care. Macrolides remain a very important part of this combination. And this I am stressing because we spoke a lot about macrolide resistance first in pneumococcus, 20 to 40%. We spoke about macrolide resistance in Mycoplasma, evolving about 8 to 11 to 12% now. However, irrespective of its resistance in pneumococcus or so, addition of azithromycin or other macrolide like clarithromycin has been shown to have a significant decrease in 30-day mortality and also increase the resolution of the cap because of its other anti-inflammatory and pleiotropic effects. So macrolide, in spite of being resistant in pneumococcus, we still add it for cap for its other effects. However, in terms of treat, it could compromise the treatment for drug-resistant mycoplasma. The role of macrolides in this severe cap and this impact of macular resistance mycoplasma was further studied and published just this month in Current Opinion in Infectious Diseases. This reiterated the fact that irrespective of the resistance in pneumococcus, as far as possible, a macrolide should be added, and avoiding a macrolide because of the resistance or assumed resistance to mycoplasma pneumonia would not be a good choice. We know that azithromycin has been one of the widely prescribed outpatient drugs in our setting, mostly for upper and lower respiratory tract infections of all kind. With significant exposure to this, the mycoplasma resistance is evolving. And since this remains an important antibiotic for us to treat severe cap or improve outcomes for community pneumonia caused by even pneumococcus, we should take all efforts to stop the abuse of azithromycin. This publication is, again, last year is kind of interesting because what they did was they divided the people who presented to primary care or your outpatient with acute respiratory infections into two groups. One group did not receive antibiotics if there were no indications in terms of clear diagnostics, abnormal chest X-ray, very high inflammatory markers, or they were identified to be sick at presentation. And there was another group who were given antibiotic as the protocols exist with macrolides, azithromycin, etc. And on follow-up, they could demonstrate that in terms of readmission rates, worsening of infection or the respiratory tract infection, etc., there was no difference between those in whom with mild, possibly viral infections, we avoided the antibiotic, and in that subgroup where we actually provided them with the antibiotic. So this should give us some confidence in avoiding use of azithromycin in the OP indiscriminately. So finally, to summarize the impact of AMR on the beta-lactam cover for CAP, we spoke about the macrolide impact on macular resistance earlier. Now, penicillin-resistant strep pneumonia and ceftriaxone resistance in pneumococcus, the clinical impact has not been well documented. However, as they say, absence of evidence is not evidence of absence. In severe disease, we fear that this could challenge the efficacy of our backbone antibiotics or our confidence in the backbone antibiotics of amoxicillin and ceftriaxone. Because in spite of the resistance or the higher MICs, with good doses of ceftriaxone, amoxicillin, what they achieve in the epithelial lining fluid, etc., which could still be effective for pneumococcus. In severe disease, invasive disease, etc., this could still be a problem. So that was one. The hypervirulent Klebsiella pneumonia being or identified as a significant pathogen for CAP, especially in those patients with risk factors, that also may prove to be a challenge for the standard amoxicillin and ceftriaxone that we use. However, thankfully, as of today, the drug resistance or multi-drug resistance among this particular hypervirulent strain is rare. Mostly, they continue to be pan-sensitive. So, but again, as we know, community-acquired ESBLs are quite high, and it's a matter of time when this may also compromise your beta-lactams. Now, coming to hospital-acquired pneumonia. So this is from JAPI this year, a significant large intensive care unit where the VAP rate was about 39 per 1,000 ventilator days. And the most predominant pathogen there was Acinetobacter in 41%, Klebsiella at 21%, Pseudomonas. So when we speak of VAP in our part of the country, we are speaking about these three pathogens, Acinetobacter, Klebsiella, and Pseudomonas aeruginosa, not MRSA or other gram-positives like in the Western literature. Now coming to Acinetobacter baumannii, something to note is that carbapenem resistance in Acinetobacter baumannii is not associated with only carbapenem use. So meaning it is not just that if you use carbapenems only at higher quantities, you will develop or you will induce carbapenem resistance in Acinetobacter baumannii. Exposure to almost any kind of antibiotics, beta-lactams, glycopeptides, piptas, polymyxins, fluoroquinolones, all of them have been shown to be related with inducing carbapenem resistance in Acinetobacter baumannii. Again, this is one of the later publications, a systematic review and meta-analysis of antibiotic exposure and the impact on antibiotic resistance. So the risk of carbapenem-resistant Acinetobacter baumannii in the ICU correlated to almost use of any antibiotics in the ICU, aminoglycosides, penicillins, carbapenems, quinolones, third generation cephalosporins, and including glycopeptides. In our setting and in many parts of the world, 50% of Acinetobacter isolates are carbapenem resistant overall. In the ICU settings, it is much more than 80%. But if you look at the overall hospital setting, more than 50% of isolates would be carbapenem resistant. On the right side, what you see are the earlier first-line antibiotics and the second-line antibiotics, which we are using now. So we used to get away with using cefepime or piptas, later the carbapenems like meropenem and aminoglycosides. But in last decade or so, for treating Acinetobacter, we are heavily banking upon polymyxins. We use colistin or polymyxin B with or without combination. And the later guidelines now suggest minocycline at the double dose as the next choice if you need to add something to polymyxin or you need to use an alternative. So right now, we try to treat this crab with these two things, polymyxins and minocycline, double dose. What we have or what we are going to expect in the next couple of months or a year, we have got some molecules lined up which would be effective in treating this. Sulbactam, Darlobactam, and Eravacycline and Cefdieracol are three which are FDA approved and being marketed outside our country. Cefepime Zidibactam is something which we are very keenly awaiting, almost being a quite broad spectrum gram-negative drug, which again is expected to be out in the market by the end of this year. So we seem to have some solutions in terms of newer antibiotics for carbapenem-resistant Acinetobacter baumannii. Coming to the resistance pattern in Klebsiella pneumoniae, the major threat in this is carbapenem resistance among Klebsiella pneumoniae, because meropenem used to be our workhorse for the ICU infections for last 2 decades. Before that, it was piptas, etc. But for the last decade too, it has been carbapenem, meropenem especially. And evolving resistance to meropenem among Klebsiella is the biggest threat in the ICUs now. If you look at the snapshot of the global incidence of carbapenem resistance among Klebsiella, India stands out, and the other red, I think, is Greece, where carbapenem resistance among Klebsiella is very significant. 60 to 75% is what that color denotes. And even in our ICUs, it's between 60 to 70%. Now, what has changed in managing this is that with the use of our rapid molecular PCRs, multiplex systems for respiratory tract infections, CAP, we already mentioned its impact in terms of determining mycoplasma. Here it is about determining the kind of carbapenem resistance or the enzymatic mechanism of carbapenem resistance. So if the molecular target detects OXA48, or it detects NDM, or it detects KPC, we have almost what we can say as designer molecules, which have been proven to be particularly good at treating certain bugs which are resistant due to these specific mechanisms. So for OXA48, we have drugs like ceftazidime-avir. With NDM, we have drugs like Aztreonam, avibactam, etc., which are very, very targeted sort of drugs with this particular kind of resistance. So in managing AMR drug-resistant Klebsiella in ICU, our leap forward has been the ability to detect the kind of carbapenemase rapidly and evolve a targeted therapy for that. And this has been shown to improve clinical outcomes. And this was published last year in scientific reports. And this was focused on OXA48, where they showed in this multicentric study that early use of a targeted therapy like ceftazidime-avir for OXA48 improves the clinical outcomes. And this early initiation and early recognition of the carbapenem resistance is important. This is a publication from India this year in the Indian Journal of Critical Care Medicine, where they showed that with early treatment, that is identifying carbapenem resistance with molecular or without in time and initiating the right targeted therapy earlier, there was no difference in mortality between a susceptible Klebsiella pneumoniae and a carbapenem resistant Klebsiella pneumoniae. Okay. So all the more reason that we should look at opportunities to identify the resistance mechanisms and move on to targeted treatment for this bug. The third common bug in the hospital-acquired pneumonia or VAP was Pseudomonas aeruginosa. Globally, a third of VAP caused by Pseudomonas and a third of the Pseudomonas was MDR. So multi-drug resistance remains quite common for Pseudomonas aeruginosa also. We call it difficult to treat Pseudomonas aeruginosa now. Of course, MBLs, especially NDM, has been a predominant mechanism of resistance in gram-negatives in our subcontinent. So MBL producing Pseudomonas aeruginosa is about 20% in India. Again, this is important because when it comes to making choices for the antibiotics as per the Western guidelines, this will have an impact on your both empiric and targeted choice. What this algorithm shows is a couple of drugs which we could use empirically for Pseudomonas aeruginosa. So in the Western literature, they have ceftriaxone tazobactam as a very specific drug, ceftazidime. They have imipenem cilastin with relebactam or cefdoricol. Of this, with the presence of MBL, only cefdoricol is expected to act. Now, if it is resistant to carbapenem and you have detected an MBL carbapenem, obviously again cefdoricol comes into place. The combinations or synergetic combinations with fosfomycin is an opportunity. If you have susceptible ones like the susceptible to ceftazidime, etc., that could be your choice. The IDSA and European guidelines prefer use of a beta-lactam whenever it is susceptible. So if ceftazidime or ceftriaxone is susceptible, that remains the single most important agent which you can use. If beta-lactams cannot be used due to resistance, then only you use the second line, and here it's almost always combination. So this publication for last year tries to give us an idea on the kind of resistance that could be expected and what kind of drug would cover that thing when we are unable to identify the right mechanism. So unlike in Klebsiella, where majority of the resistance was carbapenemase, and we are able to use a targeted multiplex system to identify the genes which are responsible for that resistance. In Pseudomonas, because of multiple kinds of resistance out there, we do not have commercially available systems that can identify all the kinds of resistance in Pseudomonas aeruginosa. So what this cartoon tries to show is that based on the resistance or the phenotypic resistance to the first line antibiotics, you might be able to come to a assumption on what could be your next line drug, even while you wait for the second line susceptibility. Right. So for if it's resistant to first line agents like quinolones and carbapenems, ceftriaxone tazobactam when it's available. If it's resistant to that, you could have an opportunity to use ceftazidime. If it is resistant to that, it could be due to AMC or PBP mutations or ROXA, where you could move on to cefdoricol. If even imipenem relebactam or cefdoricol is resistant, then you will have to look at the later newer combinations, which includes what we mentioned earlier as the cefepime zidibactam. Now, in this, as I mentioned, in spite of the multiple drugs quoted here, we neither have ceftriaxone nor cefdoricol, and even for crab, those drugs which I mentioned have not yet come to our country. So we usually treat all these Acinetobacter and Pseudomonas with polymyxins, colistin or polymyxins. So the overall colistin resistance in the ICU is slowly rising. Globally, it was about 5%. In the Asia, it is about 3.6%. Among the nosocomial pathogens in India, Enterobacter had the highest resistance to colistin at nearly 28%, Klebsiella at 16%, Pseudomonas aeruginosa at about 13%, Acinetobacter at 10%, and E. coli at about 8%. So what this shows is that while we depend a lot on colistin or polymyxins as our most dependable empiric therapy, even that fort seems to be falling. Now, how does this all impact the empiric or PCR targeted therapy for WAP? Just like how we summarize the plan for community-acquired pneumonia, for WAP, what does this information or literature tell you? For carbapenem-resistant Acinetobacter baumannii and difficult to treat Pseudomonas aeruginosa, the present molecular rapid diagnostic tests are not of much use because they have significant non-enzymatic resistance mechanisms. Therefore, if Acinetobacter baumannii or Pseudomonas aeruginosa is identified, we still go back to our old combination of polymyxins with carbapenems with high-dose minocycline. If we are able to detect Klebsiella with our rapid molecular PCR systems, then we have a utility of them because they tell you the resistance, enzymatic resistance mechanism too. So for these, we have some solutions. If it is ESBL, we could go ahead with meropenem. If it detects AMC, you could go at Biro, or if you want to spare carbapenem, you could use cefepime enmetazobactam. If it shows OXA48, you could either use cefepime enmetazobactam or go to ceftazidime-AVI. If it shows NDMs, you could go for aztreonam-AVI, or you could stick to polymyxins if you're not sure of aztreonam-AVI susceptibility. And as I told you, we are having cefepime zidibacter coming up, which could act against all of these. The clinical impact of, again, all these resistance mechanisms is a little bit difficult to quantify. There are multiple reasons to that. So this publication looks at methodological challenge that antibiotic efficacy is only one part of the equation. There are other things that determine how a patient get better or survive. Sometimes the in vitro levels of susceptibility is not correlated to how the PKPD predictions are in vivo within the patient. And sometimes drug resistance affects outcomes in set of a discordant therapy. That means you're giving something else, and that could be important. They propose certain solutions too, but this is just to reiterate the fact that why it is so difficult to find high quality outcome studies for the impact of this resistance in terms of mortality and other clinical outcomes. So to summarize the AMR and its impact on RTA management, we have good data out there that shows that antimicrobial resistance has been increasing among the respiratory tract pathogens. I have shown you enough in terms of global and national data for that. Among the community-acquired pneumonia, the antimicrobial resistance for pneumococcus, the clinical impact on is not very clear. We still need robust data in terms of that. However, we tend to believe that in severe community-acquired pneumonia with pneumococcus, which could be invasive too, these resistance mechanism to penicillin and even ceftriaxone could have a significant clinical impact, and we may need to look at alternatives or combination drugs. For mycoplasma, we have seen that there is a clinical outcome impact, not mortality, but in terms of morbidity, like length of stay and fever and cough, etc. And that if you avoid the use of macrolides because of this fear of AMR in mycoplasma, which is right now just around 10-11%, it could have an adverse impact on even pneumococcal cap. So even for pneumococcal cap, additional macrolides is better compared to not adding macrolide. When it comes to hypervirulent Klebsiella pneumonia, an evolving pathogen for our cap, as of now, it's not yet a major challenge. Mostly the strain remains pan-sensitive. However, the other routine strain, that is non-hypervirulent Klebsiella pneumonia, that still could harbor a lot of ESBLs, which we have in plenty in our community. And if the Klebsiella is ESBL, again, that could impact our choice of beta-lactam, that is of the ceftriaxone or amoxicillin as a backbone. Coming to the hospital-acquired pneumonia, that is CRAB and your DTR Pseudomonas and CREs, we have a lot of hopeful new antibiotics, ceftriaxone, durlobactam, aztreonam-avibactam, cefepime zidibactam, etc., which we hope will change the therapeutic landscape, both empiric and therapeutic for this clinical syndrome. Now, before I close, I would like to close with these two answer to these two queries from whatever information and data from the literature I've been able to source. Should this information suggest that you should change your first line choice for community-acquired pneumonia? Well, for pneumococcus, the clinical relevance in RTAs is not well established like an invasive meningitis. So if it is not a severe community-acquired pneumonia in terms of ICU admissions, etc., you may not really think that penicillin resistance or ceftriaxone resistance has an impact, I may still use ceftriaxone as the first line. Mycoplasma resistance is a threat, yes, 10 to 11%, but still not enough to change empiric choice. And since it had a bit of only a morbidity difference, not significant mortality impact, and because macrolides improve mortality in CAP when caused by pneumococcus, mostly I will still add azithromycin to my ceftriaxone. And if there is inadequate response, or if the patient again is very severely ill, then only I will choose an alternative. So for a severe CAP, either where it suggests mycoplasma or whether it's as a pneumococcus, I would change my empiric choice to an extended thing like maybe a carbapenem and doxycycline. But with mild or moderate community acquired pneumonia, my choice of ceftriaxone and azithromycin still stands good. When it comes to Klebsiella, as I mentioned, if the patient suggests hypervirulent Klebsiella, like there is liver abscess, patient is young, diabetes, etc., AMR or microbial resistance is not yet very common. So we may still get off with using ceftriaxone, and even we find ciprofloxacin quite good for this. However, we expect ESBLs, and especially from hospital, definitely. And these again will impact your use of cephalosporins and amoxiclav as the backbone. So here probably you would choose on risk factors. So somebody who has risk factors for Klebsiella, alcohol, liver disease, diabetes, organ transplantation, etc., elderly, etc., there I would modify my backbone things to cover possibly ESBL2. Should my empiric choice for VAP change? Much shorter answer. The antimicrobial resistance I am concerned here is mostly carbapenem resistance. With detection of carbapenem, the resistance mechanism to carbapenem resistance, it is possible to have a molecular mechanism targeted therapy, or with some of the historical antibiograms, a planned therapy. Right now, all this predominantly rests on polymyxins as a single broad spectrum empiric choice for carbapenem resistant in a sick patient. But these newer molecules, ceftazidime tazobactam and ceftazidime avibactam, aztreonam avibactam, cefdurocol, cefepime zidibactam, all of them will significantly change my empiric and therapeutic choice for VAP in the months and years to come. So I conclude with this short discussion on resistance and respiratory infection, and I am open to questions and comments. Thank you.
Thank you, sir. It was an insightful and very informative session. Now we can have the questions in the chat box. Dr. Bishal Gupta has asked how to detect macrolide resistant mycoplasma, and is there any rapid test for the same?
There is a rapid test for the same, but right now in commercial it is not available nor used. But as this becomes important, I'm sure this will also make it into the market. We have the molecular test which could detect the genetic mechanism to mycoplasma for macular resistance. But as I mentioned, however, commercially, like say BioFire, what we use for pneumonia respiratory panel, we don't have that in that panel as of today.
Participants can ask questions in the chat box. So, in the case if the patient is not responding to the ceftriaxone or macrolides, can we give moxifloxacin in drug-resistant mycoplasma?
So in terms of choices for a CAP, which we are presuming is due to pneumococcus or mycoplasma in terms of CAP, then the second choice, both for drug-resistant pneumococcus and for the mycoplasma, for adults, that lands on levofloxacin, as I showed you from the systematic review of therapeutic choices. So levofloxacin, because quinolone resistance among pneumococcus is on the lower side, and in the systematic review, quinolones, especially levofloxacin, fared well for adults for mycoplasma also. So that probably should be a good choice. If you want to treat both of them separately, you could go for an extended or higher dose for pneumococcus and change to tetracyclines, either doxy or minocycline for the mycoplasma. So that would be the common approach to this non-responding severe CAP.
Any other questions?
Because it seems we have a wide geographical cover in terms of global presence from multiple other countries. Maybe you can even ask anyone to, invite anyone to comment on the status in their country, because this was predominantly focused on Southeast Asia with specific focus on our country from India, obviously. And maybe some of them are experienced to share in terms of what they see in their part. Is Klebsiella as common? Are these drug resistance patterns that we discussed here relevant? Since we have time, even maybe that's also an opportunity to understand how it's in other parts. So I have a question on the role of fosfomycin used for MDR isolates in VAP. So ET VAP is not a term. I think I'll stick to VAP. Identified proven VAP, which we are treating. So fosfomycin in multiple data, smaller trials, prospective observational data and all, it has shown to have synergistic effect for Pseudomonas and Acinetobacter. Primarily, it could also be effective for NDM or MBL also if it is proven to be susceptible. So you have opportunities of using fosfomycin for Klebsiella, carbamazepine-resistant Klebsiella if it is susceptible at higher doses, obviously, about 8 grams 8th hourly or 6 grams 6th hourly. For Pseudomonas, you have an opportunity of using fosfomycin in synergy with polymyxins or other beta-lactams like ceftazidime-AVI. So that's the utility or the scope of fosfomycin in our ICU setting.
Dr. Meena Jinwal has asked about that. Fosfomycin has been used for the MDRO urinary isolates, but what is the role in MDRO healthcare-associated infection?
So for urinary isolates, this predominant use over these years has been only for cystitis, which was an oral formulation of 3 grams. 3 grams oral once a day, 1 dose or up to 3 doses was the usual thing for cystitis. However, when we talk about MDRs and hospital-acquired infections, we are talking about IV fosfomycin, and at a dose of 24 to say 27 or 24, 27 grams per day. We are talking about a high dose intravenous fosfomycin, which is uncomparable to the dose and the indication for UTI because it is cystitis and only 3 grams.
Any other questions?
All good. So maybe we get that question. Call it a day. Yeah. Afrin, want to call it a day? Stop.
Sorry, sir.
Do you want to call it a day and can we stop end the session? I think we are done.
Yes, sir, sure, sir. Thank you for your valuable insights and thank you, Dr. Dona, for moderating us. Thank you so much, sir.
Thank you, Dr. Dona, too.
Yeah, we'll wind up the session. So thank you, sir. Thank you so much, sir.
Thank you, sir.
Thank you, ma'am.